Okay, thank you for attending. We have Neil Campbell here, Executive Director of the Georgia Council on Substance Abuse. She's here to talk about how we can refocus supports and services towards some recovery-oriented systems of care. Um, Thank you again for attending, and I'll pass it on to you, Neil.
Great, thanks, Gabe. Good to see you, a fellow Georgian. I know you're kind of displaced now, but it's good to be here. And I really enjoyed my time in Idaho. I guess it was last month. Was that last month?
Yep.
Yeah, so it feels like a long, long time. Or June, I think. Anyway, yeah. So welcome, Shelby. Glad you're here. Glad everybody. It's good to talk to everybody. Yeah, like Gabe said, he asked me to speak a little bit about recovery and how we in Georgia are in the process of creating and transforming into a recovery-oriented system of care. So I'm going to go kind of through some slides that show who we are, why we need to be talking about this, some of the things that are happening on a national level, and then some of the things I actually want to end it by talking about some real practical things that people can do to start creating a vision for a transforming system. So I'll just, start by, I'm sorry, that was weird. Just recognizing who we are as an organization. So I am the Executive Director of the Georgia Council on Substance Abuse. We are a nonprofit entity in Georgia, and you can see our mission there. It's to increase the impact of recovery through education, advocacy, and training. We've been around since 2001. You can see on the right-hand side, you can read that. It's a long-term vision of what we believe and what we do. And I think other than being the executive director, I'm also a person in long-term recovery. And for me, that means last Sunday, it was 27 years since I had my last drink or illegal drug. And I speak out about my recovery because I want everybody to have the opportunities that I've had to get and to stay well. And all of us now who are working at the Georgia Council, thanks Shelby, congratulations to me. Yeah, it was a big one. I'm old is mainly the message there with 27 years. But if it weren't for my recovery, I definitely would not be here today. I wouldn't be the person I am. I have entered that phase of my recovery where I'm very grateful for everything I've been through because it's made me the person I am today. I'm a better mom, I'm a better spouse, I'm a better grandparent, I'm a better coworker, I think I'm a better boss, I'm definitely a better advocate. So it's just been, this last 27 years has been more than I ever could have imagined. So to give you more of a visual of what we do at the council, I thought I'd show you sort of the inside of my brain. This, when my board asked me for a strategic plan, I gave them this. they were pretty freaked out, and you may be too. So don't get lost in the colors. But I say this visual to demonstrate how everything we do in my agency is at the center is our peers, our recovery coaches, or we call them CARES. And I'll go over that a little bit later. That stands for Certified Addiction Recovery Empowerment Specialist. And so the four bubbles on the outside are our main projects that we're working on right now. And then sort of what's floating around in the ether are our partners, some of the things that we do during the year, sort of our approach. And so I put advocacy at the top because ultimately that's what we do. We advocate for ourselves, for our peers, and for a recovery-oriented system of care. So that's just, we'll get back to some of these things more specifically, and I can talk about sort of the new employee orientation and some of the intentional peer support work we're doing and how this all fits in to our organization as a whole. We are considered a recovery community organization. We are a member of ARCO. We'll talk about that later too, the Association of Recovery Community Organizations that was started by Faces and Voices of Recovery. We are also, these are two new projects we're doing. We're helping to respond to the opioid epidemic with the money that's coming down from the 21st Century Cures Act. And we are developing and disseminating curricula for peer support services in hospital emergency departments. And we also are staffing 3 emergency departments in Northeast Georgia for people who experience overdose. We're going to start that in September. And we are also starting, probably in October, a peer support recovery warm line. And it's basically a response system for individuals who are seeking or in recovery from opioid dependence. Actually, for anything, anybody wants support around their recovery, they're going to be able to call up 10 hours a day and talk to a peer, to someone who's in recovery. So those are two of the new things that aren't on my bubble sheet yet, but they're happening this summer. So it's been really, really busy. So we wanted to, Gabe, do you want to launch your survey, your poll? Do you have that ability? I don't hear him. So for those of you, we had someone else join us. I wanted to kind of, yeah, so the poll is open. You can, if you guys can see the screen, I can't read it from here, but it looks like you can, if you can answer that poll question. And then, do I need to do anything, Gabe? And if you could also answer in the chat box if you're a person in recovery, a treatment professional, administrator, a CPS, recovery coach, community service provider, correctional officer, law enforcement officer, or apparently in the wrong chat room. That'd be good too. So Gabe, do you want to close peer support specialist? Good, Shelby, good to hear. And do I need to close the poll? No, you do. Sorry, guys, technical difficulties.
Sorry, I had me muted there.
Yeah.
Yeah, I'll close that now.
Okay. Because I think after you close it, I can read it.
Yeah, and you can also text. Attendees can put in the chat box, if they're a peer support specialist, family member, consumer, how they would describe themselves.
Yep. We also identify, we usually put ally on that list too, because we can't have enough allies in the work that we're doing. So yeah, I also wanted to I just had a question about where you work. Are you an RCO, a recovery community organization? Do you work at a community behavioral health center, detox, outpatient, residential, recovery residence, shelter? I guess I should have put other, but you can also put that in the chat box. Or do you work at Coca-Cola, Home Depot, or Delta? Because those are 3 Atlanta-based companies. And if you do, you should move here. Let's see. I don't see any writing, but we can move on. So I'm glad to know that we have another CPS, and when we call them CPSs, it sounds like you guys call them peer support specialists. And I'll talk more about how we work with our mental health consumers as well, and the way we do it in Georgia. So soon to be CPS. Oh, hey, Kimberly. And mental health counseling office. Good. I'll go back. Yeah, good. Well, it's good to have you both here, and thanks. So one of the reasons we do what we do with the Georgia Council on Substance Abuse is that we really think we need a new way of thinking about problem use of alcohol and other drugs, and recovery in general. So I always like to start with what's working. I just wanted to, you guys can say "ah" if you want to yourselves, or you can say it to me. On the left is my son, and my grandson August, and that's my daughter, and my 2 other grandsons, Julian and Calais. I show this picture because it gives me a shot of oxytocin, and it makes me feel, I look at August especially because he's the newest, and it just makes me crazy, and it makes me have all good feelings before we start talking about the problem. So I was just going to ask if there's, what's right with you? If someone wants to put something in the chat box that's going well in your life that you want to share, I'd love to hear that. So what's working, or what's right with you today? Shelby or Kimberly? I'm picking on you guys because you're the only ones here, because I can. And Gabe's a CPSS as well. Gabe, what's right with you today? And did you guys notice that my grandsons are holding hands right here? Which is so cute. Self-care is a must, absolutely. Oh, if you start peer training on the 23rd, pedicures work for you. All right, Shelby, good. I agree with all of that. Self-care is a must. We'll talk about that a little bit later too. But I just like to start thinking about what's working, because there are so many things that are going wrong, especially with this opiate crisis that we're experiencing now. We know that a third of all inpatient hospital costs are linked to addiction and risky substance use. We also know that 9 out of 10 of us with a substance use disorder started using before the age of 18. And typically I'll have a room of over 100 people, and that information tracks. And it is about 90% of us started using alcohol and drugs before we were 18. And if you're in Georgia, virtually all state dollars for substance abuse prevention were cut in 2009, so we're not putting our money in the right place. We are just not doing this the right way. This is from the Pew Center on the States report. It was called 1 in 31, and it came out in 2009. You can find it online. You can find out where Idaho ranks. But Georgia is, you can see on this right-hand side, our national ranking. We have more than any other state on probation, adults on probation. We have more people in jail and prisons. And we're first totally in the country of people under some form of correctional supervision. We lead the nation. That's a horrible, horrible number, a horrible thing to do. So 1 out of 13 adults in Georgia is under some form of correctional supervision. We lead the nation. If you're a person of color, it's 1 out of 7. And so most people who are incarcerated also and have a conviction I'd say most, it's over 70%, have a substance use disorder and or a mental illness or both. So we have our biggest treatment provider really is our correctional system right now. So we really aren't doing this right, and we admit that all the time. If you look at this country, there's 1.5 million people, or 65% of the 2.3 million people that are incarcerated meet the clinical criteria for addiction. 4 out of 5 young people who are in the juvenile system are substance involved. I think it's probably more than that. And people who are have a substance use disorder are more likely to be reincarcerated at an earlier age and have more contact with the criminal justice system. So I'm sure none of this is new for you guys who work in the community. And that most inmates who need treatment don't receive it. And this was from 2014, but only 11% of all inmates who have a substance use disorder are getting the help that they need. So, or receiving any type of treatment, actually. So we're not doing this right. If we think of the population today as this pyramid, we have most people down here with little to no use. We also, we know that this squiggly line here is sort of, it's not a solid line because people go in and out of this. And so in and out of little or no use to very serious use, right? So, I mean, little or no use to harmful use. We know there's 310 million people in this country. About 40 million of those have what we call harmful use. And about 23 million of us have a substance use disorder. Yet only 10% of us, actually a little less than 10% of us right now, get the treatment that we need. So I don't know about you, but I can't think of any preventable, treatable, chronic health condition that only treats 10% of people who are ill. So again, we're not doing this right. If we think of where we should be concentrating our efforts, we really do need some strong prevention efforts, especially with this opiate issue, that we have to start getting education and prevention efforts out there. We want early intervention, brief interventions for these folks who have what we call harmful use. And we define that as being people who end up in the emergency room because they get in an accident because of their use, or people who continue to smoke even though they have emphysema. So people who are doing harmful things and are using alcohol and drugs even though the consequences are bad, but they haven't hit this place up here where we consider meeting the clinical criteria for a substance use disorder. Okay, so we want to save the treatment services for the folks who actually really need it, but our system isn't set up that way. At least in Georgia, everybody, we get calls all the time, people wanting referrals for folks to go to treatment for, yet they haven't even had an assessment yet, right? So this is just a construct that we like to think of why, again, the way we're not doing things right here. We also know that we spend, this is in healthcare costs, we spend about $40 billion a year for these very serious people who have a substance use disorder, diagnosed substance use disorder, and this line represents a clinical cutoff for that. Yet for people who are doing harmful use and healthcare costs, we spend about twice that much. So and SAMHSA did a study in 2006 and showed that 20% of all Medicaid costs are directly related to people with a substance use disorder. So we could save a lot of money if we were doing this differently. And then I also wanted to show one of the things that we don't think about a lot here in Georgia. We tend to think of the opiate crisis as hitting mostly the suburban white population. But if you look at these rates of death from overdose by race, you can see that, yeah, the Caucasians would have this huge increase, this huge spike. It's gone up 267%. On the right-hand side, for Latino folks, they've had a 137% increase. For people for people of color, for Black people, it's gone up 213%. And if you look at Native Americans, it's 236% increase in the last 5 years. So this is huge. It's not just happening, well, that's actually from 2010 to 2014. So we need to think about, we're going to talk about the context and how communities can really come to the table, but we have to think of recovery and people with substance use disorders in a cultural context. The figures are too small for the Asian population, so there's no real data for that, but it does show an increase. So I want to ask you guys this question, and if you could write in the chat box, and you can write more than one thing, you can write 20 things if you think of it, but I'd like you to think about, if you were thinking of the story of how you came back from something difficult, what would you say helped you? So how do we, so think about what helped you come back. And I'll tell you why we're talking about it this way. So it doesn't have to be any really deep, dark secret or any really deep, dark thing, but you may have lost a job, lost a pet, had to move, or something bad happened. Okay, so Gabe says support from friends and loved ones. Anybody else want to weigh in on that? And this is strategic. I would ask you to, we usually get people in dyads when we're doing in-person training, and we get them to talk about this with each other. A well-developed rep plan, awesome. And you're also a person in recovery, great. A good support system, great. Kimberly, all of that is exactly. So the reason we ask this question the way we do is because many times people who are not peers, people like us who are not in recovery, they say, well, look, I really can't relate. I don't know what recovery is. But everybody has come back from something difficult. So we have asked literally thousands of people this question, and we analyze this data all the time. We get the data back. And these are the top things that we hear from people in our groups that we're doing training for that helps them. And you guys said it. So there you go. Family, support system, friends, forgiveness, faith, compassion, resiliency, helping others, meaningful work, time. People have said time was the only thing that helped them. Education, hope, new beginnings, and taking action. So typically what happens is, if I were to scribe all of this on a board, people were telling me what helped them, this is what they say. The things that have the asterisks by them, the faith in helping others, that's what we hear more than anything else. And faith maybe because we're in the buckle of the Bible Belt, but I think that there is a spiritual component to a lot of people's recovery, and we hear that a lot. The other thing I think is interesting is people tell us that helping others, and there's actually some data to back that up, that giving back, just that shot of oxytocin when you do something esteemable that's actually in your brain, that can help you too. So we frame it this way because people may not understand what recovery is, but this is what it is, and this is what helps people. So when we think of a recovery-oriented system of care, what's not on this list? Well, a 15-minute unit of service is not on this list. The right diagnosis is not on this list. There's, medication is not on this list, although we do hear that occasionally, because medication does help people. But when we dig deeper into that, it's usually medication prescribed by someone that I trust, and if I have a problem with my medication, they'll listen to me and let me change it. So all of these things, again, are sort of our frame for what recovery is, and we'll go back to it. So when we think about and this is for people with substance use disorders, Mike Dennis has done a longitudinal study, And what he's found that is only a third of the people with 1 to 12 months of abstinent recovery are going to sustain it another year. Okay, and then if you go out to the 1 to 3 year mark, 2/3 of the people are going to make it another year. And so stay with me. If you go out to that 4 to 7 year mark, around 5 years of abstinence, 86% of the people are going to make it another year. So does anyone want to weigh in on why this is so? What this chart says to them? And I'll also say that even after 7 years of abstinent recovery, about 14% of the folks return to use. I'll give you a second to think about it, because I love this slide. Because what we tend to do is want people to get better really quickly. And this tells me recovery takes time, right? Yeah, thanks, Gabe. It takes time. It doesn't happen. And early recovery is very, very fragile. And we should be putting more supports and more services in that first 12 months if we want people to sustain recovery another year. Does that make sense? And dedication to recovery, right, it does take time. Yep, Shelby, that's exactly right. So, and Shelby, I actually did see your question, how can we fight against this when doctors are still prescribing? I think that one of the things that we had legislation passed last year about prescribing practices, I think we have to educate docs because they sure don't get a lot of information about recovery at all and about addiction to prescription drugs. So anyway, I just wanted to show you this chart. This is not one particular drug of choice. This is a study of 2,000 people, and actually the study is continuing. So if we actually think about what lives look like on average for people who are in recovery, that first year you start to have more clean and sober friends. You have less illegal activity and incarceration, less homelessness, less violence and victimization, less use by others that you work around and your peers. So again, it's unstable. You're fragile in this first year because very few people get better and say, oh man, that's it. After that first year, I'm done. No more problems, right? But if we look at the 1 to 3 year mark, you see a virtual elimination of illegal activity and illegal income. Your housing gets better, your job situation gets better. So we use this chart when I testify at the legislature. I usually use it to show that, recovery is public safety. So if we can put more resources toward this, that's a good thing. Get out to that 4 to 7 year mark, and I don't know about y'all, but this sure tracked with my life. You have more social and spiritual support, better mental health, your housing and living situations get better, dramatic rise in employment and income, and drop in people living below the poverty line. So recovery is a good thing. All good things come from this, right? So it comes from recovery. So that's sort of how we frame, when we think about a recovery-oriented system, we want to do things that help with this in particular, that help people get out to that, to having more time under their belt, and so their lives have time to get better. Make sense? So we think about it like in 1970, here in the 70s, for those of you who have seen that movie, The Anonymous People, that was a history of 12-step programs. We really had an advocacy vision from people in Congress, from people in Washington. There was a recovery caucus. They actually had people who were in Congress who were in recovery that were creating this advocacy vision. And then somehow today, and we could have a long conversation about that, we got to this over here on the right-hand side where treatment is the goal and recovery is seen as part of that. Because treatment wasn't all that available back then either, but we wanted to create these communities that were safe for recovery. So now we're kind of going back to that, and we think that's where we need to be, where we're really changing social norms about mental illness and addiction, and we're starting to talk about it more, where people can have communities and places where they feel safe, and yet some people are still going to need treatment, and that kind of support too. So anyway, just a way we start to think about it. And if you think of what's happened in the last 40 years in this country, we had the war on drugs that led to all of that incarceration, all of the stigma that was attached to it. There's a lot that goes into getting back to the way we were, but I think, I've got people on the line, in the evening after work, listening to what helps them in their recovery and listening to how to create a recovery-oriented system. So I think we're on our way. This is my hope slide. This is my recovery is real slide. We think about the person on the left. These are dopamine receptors. that are firing on all cylinders. This may be you guys, probably used to be my brain, but the dopamine's firing and I'm healthy. This is a person in the middle who is 1 month from detoxing from methamphetamine, and you can see that there is very little red and orange lightening up. Now think about that first year of recovery, how unstable it is. You get out to that 14 months, what do you see? Dopamine's starting to come back. People are starting to feel better. So we really need to think on a policy level. I always like to know how research feeds into policy. If we know this is true about brains, that after 14 months people are starting to heal, that it does take time, we've seen all of that, what kind of policies do we have in place in that first month when someone is, maybe has a child welfare case open or is on probation? We're giving them complicated information and rules to follow. Well, if they're only 1 month from their last use, they're not hearing very much of what we're saying, and yet many times we will lock them back up for non-compliance, take their kids away. They have other consequences. So I just show all this to show, recovery is real, it happens, it takes time. And we also celebrate many pathways to recovery. There isn't just one way. You can take the high road, you can take any road you want, but there are many pathways to recovery. And I'll talk a little bit more about that too. So I want to stop right there just for a second. Is anybody else, do you have any other questions? Or if you do, just write them in the chat box and I'll stop what I'm saying and answer your questions or any comments. Okay, because we're a half hour into this. So we believe, and you may have caught this already, that recovery happens in the community. You can start treatment, you can start recovery process in a facility or in a hospital or in a treatment program or in a psychosocial rehab program, wherever you can start that, but recovery is happening in the community. These are all pictures from events that happened in Georgia over the last several years. We've got, let's see, this is on the right-hand side, I think, is Athens, Augusta. This is Savannah on the left. There's Dublin down here. I mean, so we're not talking major metropolitan areas, but we are out in communities. When I say we, it's my organization, the Council on Substance Abuse, along with the Georgia Mental Health Consumer Network. And we're out talking to people about recovery and about, sorry, turn my other phone off. So we're out in communities a lot. And I'm going to show you how we do that. So here's kind of the road we're taking to becoming a recovery-oriented system. In 2001, you all may have heard, since you are certified peer specialists, that Georgia became the first state to have the mental health peer support become a Medicaid billable service. Sherry Jenkins Tucker, Larry Fricks, Ike Powell, that crew, Charles Willis, who passed away a couple of years ago, they were all real leaders in this movement. So I always say, in Georgia, we stand on the shoulder of giants in peer support. And I rarely make a move without the Mental Health Consumer Network being by my side. So they started that. I became the single state authority in 2005, and I wanted peer specialists for addiction. And I went to our mental health authority, and he said no. So he said, you people have sponsors. You don't need peers. And so my staff peeled me off the ceiling, and I just couldn't get it done when I was a single state authority. I left there in 2008, but continuing down the continuum, in 2007, the Mental Health Consumer Network developed community organizations called Peer Support Wellness and Respite Centers, and we currently have 5 of those. They're peer-run centers where you can go and hang out during the day, and if you need a respite service, they have beds that you can stay up to 10 days. In 2009, we had a big symposium. We brought Bill White here. We had 200 people, kind of started the buzz around a recovery-oriented system. And in 2010, so in 2008 is when I got this job here as an advocate, and I started asking the state if we could please I wanted to do peer support for people in addiction recovery. And it took me 2 years of stalking the current SSA, and she agreed. And so we were given funding in 2010 to start our Certified Addiction Recovery Empowerment Specialist training. And let's see, this says 348 trained to date. I need to update that. We actually have 443 over the we're in our 6th year of training peers. So now we have about 1,500 mental health peer specialists. We have 450 addiction peer specialists. In Georgia, we also started certified peer specialists for parents, and we also have a certified peer specialist for youth with mental health challenges. So all of these, we have over 2,000 peers in our peer workforce that have been trained in Georgia. So we think of ourselves as kind of leaders in what we're doing, and it's really good to work in a system. I give all credit to our state for having the vision to support a peer workforce. So in 2011, there's a bunch of us mental health and addiction people in recovery, providers and advocates started what we now still call the Georgia Recovery Initiative. And we started going out into communities, and we believe that you can have all these services. You can, even if our system got an influx of resources because of the way we were treating people in our state psychiatric hospitals, and we had a lawsuit, we had a bunch of resources, but we kept thinking, what's going to happen when these resources run out? And we believe that recovery is sustainability. So we started doing Recovery Month events. We started as the Georgia Recovery Initiative before we had a dime of funding from the state. We did listening sessions. We kept asking communities what helps. We established the Office of Recovery Transformation. We advocated for that in our Department of Behavioral Health and got it. We, in 2013, we started getting paid for the work a little bit more. We did 25 recovery transformation forums all over the state. And I've sent Gabe some of the flyers from these, and he can share them with y'all if you want. But we're out in communities all the time. So we're at our voice of recovery is at every new employee orientation for the State Department of Behavioral Health. And that means, so there's twice a month at 4 different hospitals, we are going in and telling our stories of recovery and of hope. And we believe we should be at every table. So when someone comes in, they don't just get the basic, this is a person who has a mental illness, this is a person who has addiction. We actually tell our stories. And that's been, we train over 1,400 people a year on this. We call it our new employee orientation, and we start telling people what they did that helped or what they can do that can help as employees of the state hospital. And it's everybody from like a food service worker up to a psychiatrist, or out to a psychiatrist. There's a whole, anybody who works for the Department of Behavioral Health hears this message of hope. So we continue through this last decade of we screened the anonymous people. We had 450 people showed up. We didn't know if anybody would show up. We did that in 2013. That was a big year. We have started collaborations with local and growing local recovery advocates. And when I was in Idaho, we talked about this, that's really important, is to lift up those local voices and to start growing leadership. And we do that by, the state gives us money to give out to local communities to have a recovery symposium. And I'll talk about those. We did 3 last year. We're going to be doing 5 this year. And when we go out to the communities, we ask them, hey, what's working here? And these are the things that they tell us is working. They say that mutual support groups, whether that be 12-step based or Celebrate Recovery is big here. Any kind of mutual support groups. They say faith communities help them. We hear that time and time again. They talk about advocacy, how we get together. I'll show you pictures of our advocacy day at the state capitol. That they say that helps. When available, the public and private treatment delivery system, they say, is helpful. And then, of course, in Georgia, everywhere we go, there's peer support, just about. So that's seen as, when we ask what's working, people tell us that. When we ask them what could be better, they want more community collaboration. People say they want access to health care and treatment services, resources for people who are coming out of prison or returning citizens. They want more funding for existing and for new and creative programs. They want more advocacy and opportunities to advocate, and transportation is always up there. I don't know how it's like in Idaho, but whenever we ask communities what they need, it's always, we need ability to get places, especially in rural communities. So if nothing else, I want you to take away that we are out in communities listening to what they say. So everything we do is based on asking those questions of what we do, what we can do in local communities. Because I can't sit in Atlanta, where I am tonight, where our offices are, and tell people in Hayhira, Georgia, or in Calhoun, Georgia, how to do their work. It has to come from the local communities. And we see ourselves as influencers of a lot of this stuff. I know this is really busy, but we have a recovery community organization network. And what I'd like you to see from this is mainly our goals of the network and the way we do the work in communities. So that's down here. First of all, we listen to local communities about how they want to support recovery, because the community in North Georgia is so different than Atlanta, which is so different than South Georgia. We bring a national perspective on RCO development, recovery community organization development, and how we can help them get up and running and sustaining. We develop local leaders, as I said, in a recovery focused in a supportive way, which means it's not just a one shot. We keep going back to communities. We promote programs and services that are deemed necessary by the local community. And we develop local awareness of the movement and what's going on. And we kind of serve as a connector in local communities. What else do we do? Let's see. Let me go real quick. I'll come back to that. No, I guess not. Okay. I have another slide in here somewhere. Gabe, I'm going to do the rude thing real quick. Let's see. Yeah, I think oh shoot, I don't think I have it on here. Yeah, sorry, I don't have it on here. So through all this work in the community, however, one of the things we came up with is a definition of recovery for Georgia, and we call it Georgia's definition of recovery. I don't know if either of you, Kimberly or Shelby, are you unmuted, either of you? Because you can help me read this. But if not, I'm going to give you some time to go ahead and read it. We got this, again, from going out into the communities and talking to people. Oh, go ahead. You can't read it. Oh, go ahead, Shelby. Do you want to read that first bullet? Maybe not.
I don't know if you can hear me.
I can. Yay, hi.
You might not have a mic or something set up.
Yeah, you do. I hear you.
Okay, recovery is a deeply personal, unique, and self-determined journey through which an individual strives to reach his or her full potential. Persons in recovery improve their health and wellness by taking responsibility in pursuing and fulfilling, contributing life while embracing the difficulties one has faced.
Beautiful. I don't know, Kimberly, are you unmuted? You may not have a mic either. So I'll say, go ahead.
Oh, I'm Kimberly.
Hey, oh, okay, hey, sorry about that. So recovery is not a gift from any system. It's nurtured by relationships and environments that provide hope, empowerment, choices, and opportunities. And then someone want to read the last one? So recovery belongs to the person. It's a right, and it's the responsibility of us all. Yeah, Shelby, your microphone must not work. Sorry. So this is, so we probably have to go back on mute. Let's see. All right, Gabe, you got it? Yeah. Okay, so this is our definition of recovery. We love this. We say it a lot. We bring it back to communities. We think it says a whole lot. We had a lot of discussion about it, and we came up with it, and we just really, again, take it back to our communities. Whenever we go and have a meeting, we bring it back and say, hey, what do we need to change about this? So I think this year we're actually going to redefine it and go back and start updating it. Some of the values and the things that we heard out in the communities was that recovery emerges from hope. And you guys can read all of these, but I love these. My favorite one is that it's age independent. We heard that time and time again. We've talked to young people as young as 16 in recovery who are choosing a lifestyle. They know that they can't use alcohol or drugs, or they have a mental illness and they're living a life of recovery, and they're just so inspirational. And we have people who are in their 70s and 80s. So it really is age independent. So when we think about recovery, this is how we sort of frame it up here. And we always say recovery shows up. This is a group of our peers we got to take to Washington, D.C. for that concert that they had on the mall for, what's the name of that organization? blocking on it right this moment, which it's not spacingaddiction.org. Yeah. So again, these are a group of our peers. We actually had close to 400 people go up there. And the way we got to go was that I asked the state, I said, hey, do you have any money laying around where we could send people up to Washington for this big event? And the state said, yes, give me a proposal. And so I stayed late one night and wrote a proposal, and we got to go. So that was fun. And then a year ago, April, I was, this is in Atlanta. It's President Obama with my bad camera at the time because it was low lighting. But he was there with, this is Justin Luke Riley from Young People in Recovery. That's Sanjay Gupta. And this is a young woman in recovery. And President Obama sat on the stage with 2 people in recovery for over 2 hours and talked to them. It was just really impressive. So there were priorities coming down from the White House about their funding priorities, and they included recovery, they included mental illness and addiction, which it was just thrilling to hear at the time, because I don't know when you hear that from the bully pulpit. Although I will say the Trump administration had a briefing, I don't know if anybody saw it today, about the opiate crisis, and they actually used the word recovery. It took us years to get the Obama administration to say recovery, but they were saying it, they were talking about treatment and recovery, so I was really encouraged, although there was nothing specific. And I live tweeted that. If anyone has a Twitter feed, you can go on our Twitter account, and I live tweeted that as it was going on, because part of it was great, but part of it was pretty disappointing. The Comprehensive Addiction and Recovery Act eventually led to the 21st Century Cures Act, to led to this $500 million of funding that came down this year, which is a good thing from the administration. And you could see some of their priorities were recovery community organizations, saving lives with the opiate overdose with the naloxone, involving women, families, veterans, and more, and a youth initiative. So we think the way it's being framed in DC these days is much better than it's been in a long time. They just had this recovery RCO Leadership Academy in DC. I happened to miss it this year because my father-in-law passed away, but we sent some people up there. Again, working with our state, they give us some funding to help people go to these events around the country, which is really good. Georgia passed a don't run, call 911 law, or Amnesty Law, back in 2014. So we were one of the first states to pass it. It's a really good law. It doesn't just include opiates. It's also, so what it says is, if you are with someone who is experiencing overdose and you call law enforcement, you cannot be arrested. You basically have amnesty from being arrested. I don't know if you have anything like that in Idaho. If you don't, you need it. It saves lives. It also made naloxone available without a prescription. So just this one organization, the Georgia Overdose Prevention Project, is keeping track of the number of kits that they give out and the people that tell them that they have reversed an overdose, and it's close to 600 people now that they've saved their lives. So it really is a life-saving thing. It was done by advocacy from the grassroots, which mainly parents who had lost their children to overdose. So we work really closely with that group. And I'm saying all this to say it's not, what we do doesn't exist in a vacuum. We are connectors. We're out there in communities. We ban the box. You cannot use a criminal history to automatically bar someone from employment, which took us a long time to do that. That's just state employment. You can still do it in a private industry, but we think the state is leading. So if you don't know about banthebox.org, you can go on there. Again, just another way you can advocate. So this is our Addiction Recovery Awareness Day that we do at the state capitol every year. This past year, we had about 600 people. We are no longer allowed to bring signs in, and we're really rowdy. We just about got kicked out. So I'm not sure we'll be allowed inside anymore, but we'll do it outside because it's still fairly warm in January in Atlanta. Not too warm though. So that's exciting. These are all mostly people in recovery and our allies. We shifted our message from, hey, we need more resources, to we're in recovery and we want to help. So we have a mental health day and an addiction day. We're probably going to eventually combine those, because if we did, we would have probably 1,500 people showing up. So right now we have them separate because they've just developed separately, but we have a ton of people show up for each of those events. We get legislators to talk. The governor usually talks. It's just it's a celebration. And since we've turned it into that, we get a lot of participation. These are all the sponsors. We had 25 sponsors last year. These are people that got their names on the back of a t-shirt and our written materials. You have some treatment programs, you got associations, just different, our ATTC, if you have one of those there, I'm sure you do. So anyway, it's a big collaborative that we get together, and we start planning it in September, and the day is usually in January. As you know, September is Recovery Month. Our state gives us about $40,000 to do a mini grant program. And again, I just asked them, I said, hey, why don't you give me some money and I'll distribute it to local communities to have Recovery Month events. And they said, sure. We're in our 5th year of doing this. We just approved 21 events last night. So they're going to happen through the month of September. It's combined, of course, people who experience mental illness or living with mental illness, people living with substance use disorder. They apply to us, and we can give up to $2,000 for events, and you can leverage that to get your community involved. And so we'll have the whole month of September, we'll be celebrating Recovery Month across Georgia with at least 21 different events. So it's really a cool thing we get to do. So I'm going to talk a little bit about our peer recovery support for the next few minutes, and then, yeah, boy, it's moving. We're almost an hour into it, you guys. So let me just ask you this question, just because I'm curious. If a recovery coach or a CPS was helping me or you, you'd want them to have how much time living in recovery? Would it be 0 to 6 months, 1 to 3 years, 4 to 7 years, 8 to 10 years? Doesn't matter as long as they're an old timer. You can use that chat box to answer that question. I'm curious about what response I get, because this is one of the questions we asked people when we were developing our peer program. Kimberly says 1 to 3 years. How about you, Shelby? And it looks like we have one other person. So we use this, we asked people across the state what they felt like when we were developing our peer. So yeah, Gabe says 1 to 3 years, maybe 4 to 7, even better. Yeah, looking at the data, right? So we asked people, we got everything from 6 months to 5 years. We settled on that 1 to 3 years. We say for our peers in our Recovery Coach Academy, you have to have 2 years of continuous recovery. Now, you could be on medication, you could be on Suboxone or be on even methadone, you can be on, we don't, you know, as long as you're your drug of choice, you're abstinent from everything else, I guess is what I'm saying. So we believe you can be in medication-assisted recovery too. So thank you for that. Thanks for playing. So we believe in the power of lived recovery experience. This was our CARES 24 class. We have about 18 people in every class. These are our peers. There were, oh no, this is last year. This is around 20, I think. Can't remember. We've done 25 classes to date. This is 22 because Larissa's in that. I'm sorry. So this is at the last day when they're getting ready to do their commencement. So these are real people. And when I did a word cloud, so twice a year, all of our peers get back together for our continuing education events. We have 2 conferences. And I asked them one time, how do you see yourselves? How do you see yourselves out there in the community? And I did a word cloud based on their responses. And this is what, I love this word cloud because it's real too. It's their real responses. Shelby is saying 4 to 7 years in recovery. I get it. So people are on fire for recovery. People see themselves as a mediator. They took a risk, trusting, they're caring, they're passionate. So anyway, that's my favorite word cloud. And this is how we keep creating a recovery-oriented system. We just keep asking communities questions, asking people in communities questions. So I told you our peer-based recovery support for addiction is this. And my organization runs this certification program, and it is the recognized certification program in Georgia. And we are called CARES, like our little logo. And the way we got to CARES is we did, like everything else, you know, for 2 years I did focus groups around the state. We did focus groups with alumni groups, with people in recovery, with CEOs of big organizations. We met with key stakeholders around the state and just developed a kind of who's with us, who do we want to help develop this peer workforce. And our Office of Addictive Diseases, who was our single state authority, I finally sold her on the idea, and she let us do a pilot project for 2 years. And that's the co-founder, George Brott, that's myself, and George, we're the ones who did those focus groups around the state, took that data, put a coalition together, an advisory group of 25 people, close to 400 years of recovery, and we came up with CARES. And our mission is to promote long-term recovery from SUD by providing experience, peer support, and advocating for self-directed care. And we came up with this vision with our big advisory committee, and our values include hope, wellness, diversity, recovery, integrity, and commitment. We probably need to revisit these at some point, but we do envision a recovery-oriented system that supports self-directed pathways to recovery by building on the strengths and resilience of individuals, families, and communities. We came up with that together. Nearly killed us. We celebrate many pathways to recovery. You don't have to just have one way. It's not just all 12-steppers. And these are our core competencies. So if you get accepted into our academy, I'm going to talk a minute about our interview process, because it's not just everybody gets in. It's pretty competitive. But we teach, how to do recovery groups, how to do individual recovery check-ins, and then we teach the competency of advocacy. And again, that's advocating for yourself, for your peers, and for a recovery-oriented system. So we're growing this. This started in, remember, 2011 was our first class. So right now we train at least a minimum of 64 a year. It actually works out to be more than that, because we always have, for every class of 18, we get between 45 and 90 applications. We do what we call Fidelity Activities, which are, we get together twice a year. We have monthly webinars. Every month we have a webinar that's based on a core competency, and we stay connected with our peers. You know, we believe the opposite of addiction is not sobriety, but it's human connection, so we stay connected. And we just did a data run. Out of our 443 peers, 49% of them are still active, and we think that's pretty good going into our 6th year. So we don't just train hundreds and hundreds of people and then forget about them. We actually stay connected. And I think that's our strength, because connection is key to recovery, right? So that's how we do it. I wanted to go back. I want to show you, when we talk about our core competencies, and I think Gabe has these available. We talked about one of the core competencies we have are doing a individual recovery check-in. We use a modified version. We modified Bill White's Recovery Capital Index, and we created a scale. So just to give you an idea of the kind of things we teach people and how to, we teach them motivational interviewing, but we also give them this form that a lot of people use in their programs that start to assess recovery capital. So you can just see some of the questions. I live in an environment free from alcohol and other drugs. I have a stable job that I enjoy that provides for my basic necessities. And you can also use these questions as sort of a conversation icebreaker. We usually just are pretty conversational with people when we use these for the scale. I have access to regular nutritious meals. I have access to recovery support groups in my community. I have a sponsor or a special mentor. There are other people who rely on me to support their own recoveries. So just questions that are, again, more conversational. It's not what's your drug of choice, at what age was the onset of your use or your mental illness, your symptoms. It's not that. You can see these questions are, get to a lot more of who a person is, and we practice these questions with each other. So then you can help use this as the basis for your to set some recovery goals. So I just wanted to give you something useful or something to think about that we use. If you have any questions about it, and you want to write to me later or have a conversation about it, we can certainly do that. The other thing I wanted to show you is we do these all recovery meetings. We teach these, and we stole this from Favor Greenville, Faces and Voices of Recovery in Greenville. We amended it sort of, but for people who don't just want to do 12-step recovery, we do what we call all recovery meetings. And we do a sign in and out sheet that's at the end, but it's nothing fancy, and you guys can use this, take it if you want. The meetings they have in Greenville are pretty special. At a lunch meeting, they'll have 50, 60 people show up. So it's just people who want to be together but don't necessarily want to be in a group in a 12-step type tradition. it just gives some basic outlines for the rules. You introduce yourself however works for you. It's okay to ask questions. And quiet crosstalk, it's okay to share more than one. So you see, this is not at all like a 12-step meeting. So it's just more free-flowing. It's open and inclusive format. So we teach how to do these, and we practice these. And then this is a way to get in contact with someone afterwards if they want to. So we have these all recovery meetings happening all over the state by our peers. Nothing fancy, just something that we teach that people can use. Let's see, where am I? Let's see this. Okay, so those are real peers. That's some of our peers, and come into a CARES Connect is what we call our 2 conferences a year that we have. We also are very, very mindful of the words that we use. I love this quote: if you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And this is actually a weed, a picture of a weed, but it's beautiful, so it's a flower, right? So we're real important. We think that's real important. One of the things, let's see, I'm getting close to the end. We work with communities on visioning, like where they want to go. We believe that every community there is work to be done. Every heart has the power to do it, and that more than anything, people will support what they help to create, which is why we go to local communities for this stuff. We don't, you know, again, we don't go in with a model and a prescription on how we do things. We literally go into communities, help them point out their strengths, and then help them mobilize. And, you know, we expect recovery from everyone. We expect recovery from every community. I just put some readings down here, some of our strategies that we use. I love this, and I think in my next webinar I'm going to talk more about this characterization of addiction as a relapsing condition, how we need to rethink that. This article is beautiful. If you want to, you can Google it. It's on williamwhitepapers.com. I just think it's really important how we tend to call this a relapsing disorder, but do we really need to be calling it that? There's also a study that was done by Faces and Voices of Recovery calling it about a life in recovery, and it points out how lives get better for people in recovery. And we believe in including people seeking or in recovery in every conversation, and I don't say that lightly. We go out, if there's not a recovering person or someone seeking recovery around the table that we're at, we go find them. And we look for a lot of diversity, and we are not, again, recovery happens in a cultural context, so you have to kind of go out and find people. And I'll just give you a quick example. The state asked us to go out. They know that we now have the reputation of being involved in recovery. You know, we have peers all over the state, and so they said, hey, we're doing a strategic plan and we want input from communities. Can you go out and do some focus groups asking these specific questions? And so we did, and we would call our peers. We went all over Georgia. We had like 6 weeks to do this, and we kept telling people, hey, we want a diverse crowd. Well, we were not getting any people of color in our focus groups, and so we had to regroup after about a week and say we got to go to them. People weren't comfortable coming to the places that we were naturally going, like community behavioral health centers. So we went to churches. We started going to churches, and we started going to places specifically where we knew we would find some diversity. So we even get it wrong sometimes, because we were surprised at that, and we're like, wait, these people know us. They know that we're inclusive, but still you got to go to communities because people have to feel safe. We also, the question we always ask is, what's right with you, or what helps you? I think that's something everybody can do. It's not that hard to do. And then I always say, we got to hold hope for someone. A lot of times people come to us and they're just hopeless, or they say they don't have any hope. They're just on the bottom, living on the bottom, you know. And so I always tell them, look, I got it. I got this. I got you. I got hope. I'll hold this hope for you until you can hold it for yourself. And that seems to, you know, people believe that. I think coming from someone in recovery, that can be really powerful, because, you know, the recovery in me can see the recovery in them pretty easily, you know, and that's one of the things that we teach in our peer class. So I just have some resources you may want. And Gabe, I think I'm finishing early because we just didn't have a lot of back and forth, but I hope that's okay. But Georgia Overdose Prevention, they have all the information on how they pass that law. Faces and Voices of Recovery. If you don't already know them, I'm on that board in interest of full disclosure. FacingAddiction.org is a good organization. This is the Georgia Mental Health Consumer Network. They have a lot of good information on theirs. And then there's a couple of videos that you can take a look at that we've been involved with. So thinking about, this has been a fast, a little over an hour. I wanted to ask you if, as you reflect back, I know I talked quickly, trying to run through it since there's only a couple of you out there. I want you to think about, you know, if you could either share, you could either unmute, we can unmute you, or you can share with us something you learned or something that you will share, or something you want to learn more about or plan to do. And I think this plan to do is really, really important, because Gabe and I talked about my next webinar being about advocacy and mobilization, how to actually get people and give you some tools to get people mobilized. So does anyone want to go, or do you want to write it in the chat room? This is so weird. I can't see any of you.
This is Kim.
Hey, Kim.
Hi.
Good to hear another voice.
I guess I'll share. I learned that Georgia was leading in peer support. So that's where all of this that we're going to go into came from. And then I will share, let's see, I took notes. What will I share? I don't know. There's a lot. There is a lot I want to learn more about, like the don't run, call 911. I don't know if we have that law here in Idaho. I want to learn more about the recovery capital scale and the recovery community organization network.
Great.
And I plan to learn more about those and share what I learn about that.
Cool.
And that's about it.
That's awesome. Yeah, that's probably the most important, what you want to learn most about, because Gabe can help you out. You know, that helps him, right, Gabe?
Yeah, definitely. I appreciate that. Any feedback like that is really helpful. We're trying to put these webinars together, and I think Neil, you made a really good point about getting out into the community. That's something that we haven't done yet. We really haven't gone out, and I think that's something. This is obviously an example of you know, lack of attendance here because we're not getting out there, maybe, and we're not, you know, connecting with people. I think that's so important, and I really hope that we can start doing more things like that.
Hey, well, let me tell you though, don't feel bad. We went down to Savannah one time. There were 6 of us. We loaded up in 3 different cars, and Savannah's like 4 hours away, right? We drove to Savannah for a community listening session at the state hospital, the state psychiatric hospital. They were supposed to be helping us coordinate it. Nobody showed up. It was hysterical because we had gone to a couple others around the state, and we were having pretty good luck. We go to Savannah, which is, it's pretty populated. Nobody showed up. I took a picture of the empty auditorium and sent it back to everybody on the Georgia Recovery Initiative. We were all freaking out. It's like nobody showed up. So I called people I knew in recovery down there, and that night we had a big listening session. Like 40 people showed up, and nobody showed up for this. So it's hard work. I mean, it's relentless work. People got to trust if they're going to spend an hour and a half. It's going to be for something they want to know about. So yeah, it just happens that way.
Yeah, and the listening sessions too. That's another thing. I really want to try and get some of those organized and get some people together, so they can bring their voice to the table, and I think that's really important. That's another thing that we haven't really been able to do. So
yeah, it's so surprising. When we sat around as the Georgia Recovery Initiative thinking, well, nobody's going to show up for these, or people were afraid that they were going to be just complaint sessions, just big bitch sessions, and none of them turned out to be. And next time I can go over specifically how we ask the questions and teach you guys how to do that, because I'm more than happy to do that if it would be helpful, because it's not you'd be surprised how many people show up and actually want to take time and learn and want to know about this stuff. But it's relentless. You got to be relentless.
Right. Well, I really appreciate you doing this and taking the time.
Sure, my pleasure. You know, we're always available. You guys, you know that, Gabe. So I just want to show you all my team. Yay, look how cute. I just want to say this guy here in the back, the redhead, got promoted. He left me. She left me. She's working for the Hilton Foundation. I don't resent it. But so we're hiring at the Georgia Council on Substance Abuse. So that's us. We're expanding a lot with our new programming. So if you want to get in touch with me, please do. And Gabe knows how. But please, you know, reach out, and I'm here.
Yeah, yeah, and thank you for the two people that attended. There was someone else, Shelby, I think she dropped off there a little while ago, but thank you for attending. And Neil's going to be doing another webinar September 5th on mobilization and advocacy, and we'll have that link up soon, and I'll send out information about that. And hopefully we can get some momentum and some support going here. So.
Absolutely. Hey, thanks, Kimberly. Thanks. And Ashley looks like she got on late, had the times mixed up, but that happens. And Shelby, thank you too. And Gabe, you know, be in touch. I'm around.
Sure. Thank you so much.
All right, right on. Take care.
All right. Take care. You too. Bye.